Hi, I'm Dr. Faranak Kamangar, and welcome to the Future of Dermatology Podcast. We're here to talk about the real science behind skin, the medical breakthroughs, the cosmetic innovations, and everything in between. Hi, we are back, and I'm very excited for today's episode. We're joined by Dr. Jonathan Chen, MD and PhD, professor at Stanford, also clinician, and now the director for medical education in artificial intelligence. I have loved watching anything that Dr. Chen has put out, his publications, anytime he speaks on a podcast or a lecture, and I've just learned so much from you. I'm so happy to have you here today.
Great to be here. It should be a fun discussion. It sounds like you haven't even discovered some of the other types of stuff I've uploaded to my YouTube and Instagram channels.
I have seen them. I've seen your YouTube with your amazing magic. If that's the, I did a deep dive, and I think that's another amazing thing is I think you're just so creative in how you think, and that is brought into your AI research. But also you have this all these other sides of magic and perception, which I think a lot of it actually can relate into the AI world. I was thinking about what I want to ask you, and it was about 50 questions or so, and we have about 15 minutes. So I thought that's a good match. But we could start anywhere, and of course, tell us a little bit more about what you and your lab are working on as well. But some of the themes that I've just loved that you've talked about that I haven't seen others talked about. Of course, there's your research that actually was like viral, and all newsletters about how, or newspapers about how AI actually can outperform the physician, and maybe sometimes we could hold the AI back, which is an interesting point because we're always looking at, is the AI going to be good enough for us? You've talked so much about just the trust paradox of, do we trust the AI, and what's the safety in bringing these things live into our diagnostics and decision makings, and how it can change your behaviors as physicians. So what does that mean? So there's so much there. And then of course, we just also chatted about the medical education part. I mean, the new medical students that we're teaching, like all these implications of, to me, I taught a course at UC Davis and was kind of thinking, man, this is so different than how we train, because it's the first group of kind of cyborg med students that are going to be trained with both. But I mean, that a lot to catch on, but I'd love to just get your thoughts, and feel free to start anywhere in any of those topics.
Oh gosh, it's too much to cover, but too much fun things. Back when I was a medical student 20 years ago, I remember when I was just like, oh my gosh, why am I memorizing all these bugs and drugs? It just makes no sense. It's just so obvious a computer could do this better than I would. And I'm studying really hard, and still it just doesn't make sense. And so I've been trying to make the computer that would like replace my homework a long time ago. And now the past years, like, oh my gosh, I think we're here. I think we've arrived. I've been trying to do something like this for years, but the technology wasn't quite ready. And of course, ChatGPT exploded on the scene a few years ago. And immediately I wanted to try multiple things on like complex medical assessment and reasoning. And of course, the very high profile stuff we got, because the results were not what we expected, was on complex diagnostic cases. Let's see how well a doctor does with usual resources, up-to-date Google, PubMed. And then we randomized another half of doctors. What if we gave Max GPT-4, one of these language model chatbot AI systems? And strangely, it didn't really make that much difference. And we're like, what? What happened? That's not what was supposed to happen, because it turns out you just ask GPT-4 by itself, it actually does better than all of the doctors. Like, whoa, wait a minute. What is going on here? Not only does that imply that the computer was unusually good at this task, it's the humans were like making the computer worse. Like get out of the way, humans, right? You're just slowing the computer down. Let the robots take over already. And I definitely don't think that's the conclusion we should draw, but it sure makes it sound like that. And so all this work and the things I think we talk about to unpack, like, why did that happen? What do we need to figure out now to make the combination make sense?
No, I love read that work, because I think at the time everyone was looking at the benchmarks and is it going to be as good as us? And this just, turned it on its head. It's like, well, what if it's already as good in some tasks? Of course, it's not going to do all the things that doctors do, but I think we all kind of know at this point that in some tasks, it's way better, right?
It is, and it's not the perfect analogy, but I do imagine it's like, well, are you better than long division at a calculator? Of course not. It doesn't bother you that a calculator is better than you at long division, right? But what is strange is a human using a calculator should do math problems better than the calculator by itself. That seems pretty reasonable assumption. This is the fundamental theorem of informatics, where a human plus computer should do better than either alone. And then finding these results, and we're not the only ones to have done this. This wasn't a fluke. There have been a lot of radiology, mammogram type studies. There's one of Google's, I think, AMI studies showed a similar phenomenon. And now we have multiple studies showing this weird phenomena that the human computer is not doing as well on certain tasks. That doesn't mean the holistic completion of medical care. But it really begs these uncomfortable questions like, oh, wait a minute, maybe some of our fundamental assumptions are either flawed or being challenged, and we need to rethink how do you actually put things back together. Because patient care really depends on doing the best job, and maybe our assumed structures of practice and education need to be adjusted a little bit so that we can meet that potential.
No, absolutely. And, I do a lot of my work on more the large language models with dermatology, but looking at the data from like the visual dermatology world where everyone's trying to diagnose melanomas from moles and differentiate those, I started looking at some of this research and I was like, well, this model has this sensitivity and this specificity and all this. And I'm like, wait, what's my sensitivity and specificity? And I looked it up once. I was like, how much biopsies am I doing to actually find one melanoma? Because we don't really look at ourselves that way. We're like, well, I'm the perfect model of what the dermatologist should be. But I was like, oh man, if you really look at it, we're biopsying a bunch of moles too before we get to a melanoma.
Yeah. Well, I mean, that's great that you're also thoughtful enough to have that directed and quantitative feedback. Otherwise, most people go by vibes. People complain about vibe coding, but it's like most of medical practice, most of my medical trainees, I realize they learn by vibes and heuristics, intuition, or very blunt rules. If fever, then order blood culture. If pain, then order oxycodone. I mean, that's not a very good reaction, but that's what happens, right? If mole, then consider biopsy. But then you have some intuition for it. And that intuition actually is very powerful. It's actually, you can actually learn a lot at pattern recognition. The experience actually is very hard to replicate. And we'll get into it more, but more than just, I've seen this before. Because that's the only thing I've seen this before. I mean, a computer can see a million cases more than we ever could, right? But it's that you learn judgment. But there's implications by biopsy. That's right on the patient's face. You can leave a scar there. You have to really be thoughtful about whether you're going in or not. But on the other hand, if you have this family history, well, I mean, it could be actually serious condition if you miss this too. Is it worth it to do this? And I like to say that worth it. Is it worth it to do? Worth it is not a question of facts, evidence, or statistics. Worth it is a question of values and preferences. And that's something humans provide. Computers cannot provide that. And how we disentangle where we're all needed for different parts.
Yeah, Eddie, philosophically, it's so interesting because there's the technology, there's how we interface, and then there is this whole world of shared medical decision making. Like maybe you're chatting with the patient about, do we take off this mole or not? I mean, like what parts can AI replace? I guess the whole question is, can we be entirely replaced, right? That's what the articles kind of, the one-liners are always like, the AI did better, so it replaced. But when you dig down, you see that the AI just did one task better. I mean, what elements do you feel like are still so innately human that will still have jobs?
Ooh, it's
that's a hard one. That's a philosophical hard one.
If I don't think it's any one thing. I don't think it's any one thing, because if it is, like, eventually a computer or something else probably could do it. That's
true. If we can basically put terms to it, we could probably create it. You're right.
Yeah. Is it knowledge? Like, it clearly is not. A lot of AIs already have more knowledge than most, if the doctors already. And if they don't yet, like, it'll very clearly keep advancing. It's clearly not knowledge. Although I think you need knowledge. But then that knowledge, what you have a judgment. That's the very key distinguishing factor, probably the most important one. Some people think, oh, well, it's empathy. It's a bedside manner. Another human wants to talk to another human and lay their hands on. Like, I actually really don't think that's the answer. I really don't. I think having empathy and bedside manner, that makes you a better doctor or a clinician for sure. But there are many very empathetic non-physician humans, right? A nurse can have great empathy. A social worker can have great empathy. An actor can have great empathy. I would say, like, a golden retriever would be nicer to people than half the doctors I know. True. If we just strap an AI talk box onto a golden retriever, that makes a clinician, like, obviously not. Right?
That would immediately make us obsolete.
It's that, plus it's not just liability. You can sue me. It's you take responsibility for your patient's care in a certain way. You have ownership of that situation. That means something. You have this accountability. This is why we don't allow AI to be co-authors on a paper. Not because it can't write the paper. It clearly can write the paper. It's because it can't take accountability for what it says. So it doesn't actually mean something. There's a lack of authenticity. But when you have knowledge, judgment, empathy, persuasion, influence, and responsibility, and it has to all be in one person or maybe one entity one day, that was actually what completes a kind of healthcare professional. Because, by the way, you can't have one of those without the other. Or if you did, it doesn't mean anything. It's just a tool. What is it? I take responsibility for your mole or your cancer, although I have no knowledge. I'm not a dermatologist. That means nothing. I have no idea what that means if I say that, right? And knowing it is not enough unless you combine the other pieces. So I think that is what a human professional brings all of those together. But each one of those parts, each one of those tools, each one of those aspects, more and more we're going to see very powerful tools that probably can do as well, maybe even better than humans at certain subtasks.
Yeah, no, it's fantastic. Actually, that also now makes me think of like the work you're doing with the medical education piece. So we're kind of looking at what pieces in theory coexist in an attending or a finished product. If we go all the way at the beginning of how we're kind of training medical students now, like what are the things you're focusing on? I know one of the things I asked, everyone's using AI. I think that was one thing. Everybody raise your hand if you're using AI. They all were, and then they said different ones. And then I asked what things they're kind of afraid of, and a lot of the things that came up was kind of their critical reasoning. They're worried that this is going to make them less sharp, or like that it's going to be a crutch. But I'd love to hear what themes you're seeing, or if you have any advice for like other attendings that are kind of entering this space on how do you teach your medical students? Do you just go into, okay, let's teach you how to prompt and work with the AI the best way, how to assess the answer, make sure there's no hallucinations, or is there like a broader subset of like how to start teaching?
All of the above, all of the above. And it's a real issue. A few years ago, as things were emerging, there was no official policy at all or approach. And many reactions from even educators in our school were, just ban the technology. Oh my gosh, don't let our students use this. Don't let our children use this. Don't let anybody use this. We have no idea how to cope with this thing. So I think we're fortunately past the phase of like, for one, that's completely impractical to ban it. It's unenforceable. And I don't even think it's the right thing. It's like, no, you better get your people to learn how to use this as rapidly as possible. Otherwise, they're going to get left behind and be in a vulnerable position and not actually providing the best care that they could be. I'll give some anecdotes to punctuate why it is a real tension. Actually, in some of our medical students from the prior year, on their medical reasoning class, their homework, dude, they're killing it. They're acing the homework. And then when it came back to the closed book exam, like, whoa, a lot of students did really bad on the closed book exam, a lot more than usual. What happened, guys? You did great on the homework. It's obvious what happened, right? They just use AI to do their homework. And they forgot, no, the point was the homework isn't to make you do homework. The point is the struggling through the homework is what makes you learn. And I think they missed that part of the lesson, unfortunately, or they didn't get like that was the point of it. So there's a real challenge here. Some students are self-aware enough. Oh no, if I always depend on AI to give me the answer for differential and management plan, then I never actually bother to learn that. And then actually I'm left in a vulnerable position. And I can't use the AI effectively more because I don't have a good judgment about what's credible or not. So if used well, AI can be the best teacher, the best tutor you've ever had. But misused, it's just like crutch the shortcut that you become dependent on, and then you become a mindless. I'm going to be kind of snarky here. You become a mindless technician.
Right.
Who needs you to be a doctor anymore? Maybe you shouldn't be a doctor if that's how you're going to operate, because that ends up being a dangerous position to be in.
No, 100%. I think it's such a slippery line, because you could really use it as this tool that takes care of maybe the mundane tasks, so you can go on to this like complex stuff and reason with it and like make yourself better. But if you don't do that second part, you just did it to do your mundane tasks. You're kind of limiting yourself. Yeah.
It's sort of just fun analogy to think about. It's just very bizarre things that AI is, but it can't handle this complex thing, or actually complex mathematical type problems. That's actually exactly what AI tends to be very good at. And now even language, it's shockingly good at. It tends to be common sense it would struggle with a little bit more. That's been the case before, but now things are adapting. And the joke is, we used to imagine, wouldn't it be great if computers, AI came in here, like it could like fold my laundry for me, and that way I'd have the time and freedom to like write poetry and sing songs. And actually, AI now is actually really good at writing poetry and making songs, and we're still stuck folding the laundry.
It reversed. It's true. No, it's really true, and it's so interesting too. Kind of going through this with the med students. I wonder how do you approach like prompting? I guess it seems like most docs are using AI now, right? The research kind of shows now that like the cat's out of the bag, like whether an institution allows you or doesn't allow you, it has policies. On the grounds, people are on the phone or on their lap. They're using it. They're using different models. But maybe the how they use it, because it's sort of like everyone's on their own kind of thing, is different. So the prompting is different. How people are asking questions are different. What advice do you have for docs to just prompt
Sure,
better
sure.
or interface better, so you're getting like better results, basically?
Oh gosh, a few things. For one, you should definitely check out Shivam Vadak and Dong Yao are two, now my associate directors of medical education and artificial intelligence. They have a dedicated hour, if not a 2 hour, like prompt engineering workshop. But there are videos of parts of this online right now, including on our website and a Stanford YouTube page. And it's specifically designed for like a clinician or a learner, someone who's not a tech person. Like you're interested in tech, but you don't really care that much about how the tech works, but you need to know how to use this. And a lot of it's like understanding the variations, prompting, and how that could affect the outputs you get. So that's very much specifically for that. A couple principles I'll lay out. We have curriculum now in our first year and our third year, and also to CME grand rounds. Like we're reaching out to everybody. Everybody's a learner at this point. About what you expect. Beware of confabulation, hallucination. Beware about biases and sources. The reality is a lot of these are not solved problems, but are getting addressed. One of the ones that we're learning from a recent study we did, well, if AI is so good, then the doctors don't learn from it. It's like maybe if the AI teaches the person how to use it in real time, that can help. And it does help. But then it begs this question, who should go first? Do you have the AI write your first draft and then you come in and you edit it and you fix it? Or do you write the first draft with a couple bullet points and you ask the AI to turn that into the final version? It turns out both can work, both help, and both give you better results in terms of better answers. But both ways make different kinds of errors because in both cases you have anchoring bias, or in the extreme case you have sycophancy. So whoever goes first, the second person or the second computer has a strong tendency to just agree with the first run. If AI writes the first answer like, that actually does look pretty basically right. Okay, sure, you just sign it. You don't even think that hard about it, even if it wasn't right. And if you give an answer, the AIs, they are highly tuned to please you. They really want you to like it. They are very agreeable by default, because these things are not optimized to be correct or useful. They are optimized to make you want to come back. And a lot of people like it when somebody agrees with them. So if you say something wrong, you say, hey, how are opioids good for heart failure? It'll say, I'm not sure that's true. But if you say so, okay, yeah, this is how it's good. It really wants to agree with you. So that's actually dangerous if you actually want a correct objective answer. You have to not tell it what you're thinking. Give it the situation, but don't tell it what you're thinking. Otherwise, it's just going to try to agree with you.
That's a great tip, actually. And then initially, for like Derm GPT, what we had is we had set it to, we're like, don't give an answer if you're not 100% right, and this and this and this, and just being like, completely dogmatic about it. And then sometimes we wouldn't give an answer, and we're like, oh, well, then people don't come back. But then at some point, you have to make it human behavior, user friendly. It's almost like, well, I don't know if this is a good analogy, but it's almost like the patient satisfaction scores. They're helpful in some ways, but trying to please the situation maximally is not always going to give you like an optimal medical outcome, basically.
It's a real tension. I like that analogy of medicine. It's like patient satisfaction clearly cannot be the priority, but it also is a priority, right? Because if your patients hate you and don't trust you, even if you are right, it doesn't matter because they won't listen to you. And I do tell, like, this is actually the real human skill in medicine. It's knowledge is important, but if you know the vaccine, if you know the statin, but your patient doesn't want to take it, like, who cares what you know? If the insurance company won't agree to pay for the procedure, like, who cares what you know? You have to also understand where the other person's coming from and be able to persuade and influence them to do something that matters. Otherwise, being right is just not enough if you actually want to affect and impact people's lives.
No, absolutely. But that's a great tip to just know, like, you can bias it by giving too much of your info. Anything else that you put in your prompts? Do you specifically say, don't give an answer if you don't know? Or like, do you put anything in there to try to just manually decrease hallucinations?
We've tried that and it doesn't work anyway. You can try all that. And if it did work, the foundation models, the techniques, they would incorporate that into the underlying system anyway. So it's actually not worth learning very fancy prompting techniques. You could iterate a few times, you can have it double check, but I actually don't bother that much with it.
And that's good to know. Like the master prompt just takes over anyway, right? It just keeps doing it.
Yeah. If you found some clever prompting strategy that helped, it would just start to get incorporated with the core system anyway. I will say a little bit tangential, but I think it's very provocative. It's one of the most powerful things I found with these systems. We have ones that are even tied to our electronic medical record. You can scan the chart. I was on service in the hospital last month. Oh, a patient with fever, unknown origin. Hey, can you review all the tests and give a differential diagnosis? Like, it's fine. It's good. It's nice. Hey, I have a patient with weird allergies, and I don't even know what this test is. Can you explain what that is? And explain. And that was cool. It was great. I could have went to UpToDate or Google, and I could have looked that up. It maybe made it a little bit faster, but I actually wouldn't say it didn't really change my life all that much. Just a nice tool. What really was like dramatically different is like that you could not have even conceived of 3 years ago is you can like talk to these things and have conversations and break things down. So I've practiced tough patient conversations about ethical dilemmas. And whoa, this thing is providing better counseling than I've done in real life. And so now before I go into a tough patient conversation, I practice with the chatbot. Before I go into a business negotiation, I practice with the chatbot. Before I ask my wife for something, I practice with the chatbot. You want to say something in real life you can't take back. And here's the pointed lesson on this one that I would recommend. You should really try this. You have to go to the chatbot and say, I want to role play a conversation. And when you do it again, but take the other side's perspective and say, take on the other personality. And then you actually will gain a lot of empathy and perspective about what another person's thinking and how you modulate that. I did this for a business negotiation, and by default, sycophantic. The thing wants to be really nice and so good. Oh, I see you're upset about this business arrangement. Let me see how I can help you figure that out. And I'm like, that is not what this conversation will be like. This person's going to be super hot-headed, super confrontational, super disagreeable. And then when you tell it that, boom, the personality will change and is very jarring and actually felt very uncomfortable and threatening, kind of. But okay, that's good. That's good because the whole point is I want to practice this in this safe, low stakes environment before I walk into the real one.
No, I love it actually. That's again kind of turning it on its head because everyone thinks of the machine and AI as the more algorithmic thing and like the thing that would be better at that kind of agentic retrieval of stuff in the chart and getting you that info. Whereas you kind of found that to be like, this is nice, but didn't change life. But then, but then you wouldn't think of that like reasoning and conversation is the thing that the AI would be best at. And you've kind of found that to be actually the more valuable part of the tool.
Punctuate a little bit more again when I was on service. I use those things, but it was really like I was struggling with this really nasty ethical dilemma. A patient who doesn't clearly have capacity to make decisions, but still can express their wishes of what should you do. And oh man, it was quite a struggle. And I had, like the case management's up in my face telling me what to do. Ethics committee's up in my face what to do. Residents in my face, like they're not going to do that. I got the CMO directly messaging me like you have to just do something. Oh, holy crap, what am I supposed to do about this? I was like literally up late at night, multiple nights, like it wasn't like what's the right diagnosis, what's the right medication. It's like how do you handle this situation to resolve this conflict? And what really helped me was I talked to ChatGPT at 2 a.m. at night. And like, here's the situation. And I did not tell it what I thought, because I know once I tell it what I thought, it's just going to agree with me. I just tell it, here's the situation. What's the right way to think about this? And it has a very thoughtful, very grounded ethical framework. And I'm like, no, that can't be right. I pushed out, what about this? What about that? What about this? And it just had a very like, what a nuanced way to think about it. Here's the analogy to break it down. And by the end of it, by 3 a.m., I was like, wow, this actually makes a lot of sense. And it changed my mind about how to think about the situation. And the next morning, I had like absolute confidence. I know how to approach this now in a way that I was completely struggling with before that.
That's amazing. And I wonder if like over time, AI will take this place for us. It's not like the easy diagnoses and these little like, things that we can do anyway. It's these complex diagnoses that no one can figure out, or these complex kind of conversation. So it's so interesting. Do you find any models or like your go-to? Do you find like for that kind of conversation, ChatGPT is a little bit more grounded? I've kind of found I've played around with different models. I think I got Claude to curse at me once. So I was like, okay, you can push it. you can push the limits here. You can push it. ChatGPT, I haven't been able to get it to do that. So I wonder if it has more of a
It has a lot more guardrails.
It has more guardrails. Yep. And then I haven't gone too much into like Grok and those worlds, but I've just heard stories of like it said this to a kid, or things like that. So
that
I wonder
designed
to be a little provocative,
more edgy.
I guess, a little edgy. So I wonder if like maybe for these, like, do you feel like ChatGPT is the right place to go if you're trying to do this kind of task of reasoning through maybe like a difficult case? Or
I think a lot of them are converging at very high capability, and it's more what personality do you want? And given that you can just tell the thing, I want your personality to be like this. I actually don't have a very strong preference. I happen to use ChatGPT because I'm used to it, but a lot of my team members using Anthropic's Claude because they do a lot of coding. They do a lot of software. And
true. Their Claude is the best for that.
Incredible they're just building like whole websites overnight based on a lot of these toolings. Gemini is like integrated with search as well. I think they have a lot more guardrails. I actually don't have fun talking to Gemini as much because it will very quickly say, that's not an appropriate thing to ask. I'm not going to answer that. Like, it wasn't that big a deal. I was like, generate 10 versions of a joke or something like this. You shouldn't be joking about doctors, Dr. Chen. And I'm like,
right.
I'm talking to somebody else.
Yes, that's true. Sometimes it's too much, too many guardrails.
So most of these frontier models are quite capable of finding a personality. That's like a weird thing to say, right? That favors what you need for different ones. And it'll change 6 months from now anyway.
I agree. And I think the models are really good. I think that's what we don't realize. I mean, there's all these companies that are coming around with medical AI, and they're saying we're going to change the world because our thing is the best. But really, when you look, just the foundational models are pretty good, actually. You really don't need to go to these. I think like for us, for the derm world, we just have like a little more like derm tools associated with it. So the thing you need is just like right there. But as far as their thinking and their reasoning, I mean, I think, the LLMs are kind of being commoditized at this point.
Strangely,
they're amazing.
Yeah, this kind of arms race happened. And then once the idea that it could be done, then it all chased around. I kind of like an analogy, a couple of years ago, I was at a scientific conference and like, oh man, what is there left for academia to do when like the big tech companies can make this giant model and we can never compete? And my thought was like, why would you compete with them? It's like saying, "What I wanted to make my own internet, but now there's the regular internet.
There's regular internet.
Like, what? Why would you try to make your own internet? Like the internet just exists. You should. It's not like there's no more work left to do. Now use the internet as a commodity, as a tool, and there's lots of very important, very powerful applications and tools and systems you can build on top of that. I think it's a much more compelling thing. So medically focused ones that use a foundation model under the hood, but uses dermatology-specific resources integrated with your systems, has thoughtful interactions and design for the way you and your patients and your doctors would use it. That's actually the much more valuable thing to do. That a foundation model, a Google or an OpenAI is not going to bother to do that. That's not really what they're supposed to do.
That's true. And like for any physicians listening, like the main technology is there. It's our intuition and our workflows and our creativity that's going to make it better and have actually more interesting tools in the clinical space. But so many interesting things. We do such great work. Let me know if there's anything we missed, any publications you have coming out, anything super interesting we should talk about.
Oh gosh, there's too many to keep up. But we have things where we're deploying things in live health systems, doing randomized trials, these smart alerts rather than these dumb alerts. So it gives you more personalized guidance. One that's in preprint right now, so I'm not going to describe too much details. We have to get it through peer review. But the scientific peer review cannot keep up with the pace technology movement. We had studies that were done like 9 months ago, and it was cutting edge. We used the first reasoning model, 01 preview. It's like over 9 months old. I mean, the peer review just takes forever. How do you kind of cope with this? But a study that's pretty compelling, I think, points to a lot of future directions, is we did, consult cases. Primary care doctor sends an email to a specialist, gets an email answer back. So it's real cases. It's not simulated vignettes. It's not textbook questions. It's like a real doctor's asking another doctor for help and evaluating how language models answer those, but not in accuracy. This isn't like a multiple choice test. It's not like knowledge. It's safety. And I bet you work with doctors or trainees who they're really smart. They memorize the whole book, but that doesn't make them safe. They're like, whoa. Just because that's right doesn't mean you can just do it. Dude, you forgot to do this, but you did this when you shouldn't do that. It turns out it's not the same question that you have to ask. And so we broke these down and found it's not perfectly correlated. Being right on medical knowledge exams was not correlated with being safe in making the right decisions to do and not do things. And 10 to 20% of the cases we evaluated out of 100, even these frontier models would have done something that potentially could have caused severe harm. So it doesn't mean this stuff can just practice medicine yet. I think we're headed towards that direction, but it's not quite there yet. We're defining the benchmark. And what was probably most interesting is that most often the error was an error of omission. So I gave this example in my grand rounds where one of the real questions a primary care doctor asked a specialist, I assume it was dermatology, hey, I have a patient, they're 60 years old, they have COPD, 10-pack year smoking history. They have a bunch of seborrheic keratoses, all these SKs popping up all over their body in the past few months. Is that normal? It's like, it's just a benign lesion, so it probably doesn't matter. But they're like, there's a whole bunch of them sprouting all over the place. And then the specialist responds like, that could be a Leser-Trellat sign. That's actually a paraneoplastic syndrome. The patient probably has cancer. You need to go do some endoscopies, go check and look for that. 20% of the language models basically recognize that there was a syndrome here that need to be evaluated. But that means 80% of them said nothing. Said, I don't know. It's probably means nothing. Oh, that's dangerous. The patient probably had something and it was being completely missed. Then again, we asked 10 internal medicine physicians the same scenario, and 0% of them said to do anything about it. Because they also, I don't know, SK, benign lesion, don't do anything. So it's these doing nothing is not doing no harm. You can actually harm a lot of people if you don't recognize what you need to intervene.
That's a really great study. It's true. And then comparing it again to our own sensitivity and specificity of picking things up too. It's like it really just is getting down to the nitty gritty of kind of what these models can do. Super excited to get to read that paper when it's out, but you're so right. The peer review process is not keeping up with the technology articles. So, but such an important point with safety, trust. I mean, I think it comes down to that and understanding what AI can and cannot do. Because I mean, I think like many of the profit-driven companies are saying, "Oh, it can do all this and it's going to save the world." It's like, no, it can't really do all of that just yet. Like, let's slow down. Let's not take it completely at its word when it gives you an answer.
I mean, this is a great depth of thing there. Literally, like part of why I integrate magic into my presentations is I also for one, it's for fun, so people will pay attention, right? You need this hook. It's a presentation technique, but it also as an analogy. It's like that looked pretty real, didn't it? But it's not. It must be an illusion. You have to be able to distinguish the difference because too often I have people approach me and say, "Hey, I got this nasty problem. Let's just throw some AI at it and it'll solve it." I'm like, it's AI's not magic. It's not. People treat it like it is magic and just do anything you want in any way you want. It is remarkably powerful and capable, and it is very disruptive. That doesn't just mean it does anything you want it to do. You have to think very hard about your individual workflows and processes, and now that connection can be very compelling.
Absolutely. And I just don't, we didn't see any magic at all during this presentation. Should we incorporate some magic tricks into because half will see it on you, most are listening.
For those like listening, you're missing out. I'm just like a Rubik's Cube, right? Over 40.
Yeah, for those listening, switch over to YouTube right now to watch this.
But imagine if you use very deliberate techniques, you can solve it much more.
Oh my gosh, that's a trick one, right? Is that a trick?
Everybody thinks it's a trick cube. No, it is not. This actually would work live. I could be an AI-generated avatar for all I know. But look, watch close, okay? Don't blink, otherwise you'll miss the moment that I solved it.
I did miss it. Oh my gosh.
Okay, some people think it's because this has got a trick cube and then there's like a reset button in it or something. Like, no, it's
right.
It's
I'm really watching this. I'm like, where's the button he's pushing?
And it's not like it just solves itself. Or it has a switch where it can go from like solved to unsolved, solved. That's not what's happening.
This is so cool.
Is this just an illusion like in the AI generated age? You can't tell what's real versus not. It's actually beware people scamming you too, which I'm not here. This is really mixed on all 6 sides, but apply different techniques. A complex problem solvable much more.
Oh my gosh. How is this? I'm going to get this video from Steph, our podcast producer, and watch that 10 times and look for the trick button. There has to be a trick button. That was so good.
It's not magic. It's not a trick. It is algorithms. It's highly advanced algorithms applied in a deliberate way to a complex problem. And it looks like magic, but there is a valid explanation for what is happening. Oh my
gosh, that was just fantastic. And anybody who is listening on like Spotify or Apple Podcasts, switch over to YouTube and see that. That was the coolest thing with the Rubik's Cube that Dr. Chen just did. We should do actually, sometimes we'll do like little shorts and post it. We have to do that too. And also we'll post all the links. I forgot to mention all the links you mentioned with the prompting and all of that. Those are so priceless. So we'll get all of that from you as well. And then this is the Future of Derm podcast. So at the end, we always say, what are you excited about for the future of dermatology? But we could switch that out for AI, unless there is something specific about the future of dermatology you're very excited about as well. Or what are you excited about? Yeah.
I wonder if it's even the future. Like, it's already the present. Like, the futures came so fast that what was the future last year is like, it's kind of already here. As a medicine doctor, I'm really bad at dermatology, right? I'm really bad at skin lesions. And so for years, Effort had electronic consult. That was actually where it started, where, hey, well, take a picture of the thing. And then if you can't get an appointment with dermatology, a dermatologist will at least look at it over the computer and like get you a basic answer this is fine, don't worry about it. Versus like, this does look bad. We're going to find a way to get them in the clinic next week, right? So you can triage that. But then couldn't it be where a computer is just doing that, even a human? Because there's more things that can be assessed than can be done practically, even with a human reading on the other end. And it's surprised me that isn't more widespread. I expect that to only happen a lot more where we have the capability for automated systems, not to do everything. You still need a human to do the procedure, right? You need a human to do some of the counseling. But a lot of the core cases, I think more and more we actually are going to see quote unquote AI doctors not that far. I would not have said this out loud 3 years ago because I know people, it would make people angry and mad. But now I think I think it's happening in the not that far future anymore.
Yeah, no, I love the answer. One, that it's not even the future, we're already here. And second is, in a perfect world, we're like, no, we shouldn't use the AI doctor, but really, like for subspecialties like derm, we're less than 2% of the house of medicine.
Yeah.
If someone's going to wait 6 months to see us, that's not perfect either.
Yeah.
So if you have a system that's maybe wrong sometimes, but gets you an answer, more often than not, it's kind of working in that imperfect world anyway, because our current reality isn't like, it's not like everyone's in the dermatology office tomorrow at 8 a.m. anyway. So
right.
We should be leveraging these technology tools. But thank you so much. This was such an amazing conversation. I'm very excited to read your safety and AI paper coming out. And we'll link all of the links to the prompt courses. I'm actually going to watch those too. Those sound fantastic. But thank you so much.
This has been great. Thanks for connecting, and I'm happy to catch you again.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.